Week 6, last week of content. So we're going to talk about nursing care of the child with alteration in behavior, cognition, or development. Child abuse is also included in this podcast. All right, some things that might influence a child's behavior. Of course, genetic characteristics or biological influences will definitely affect their behavior. Their physical health. If they are a failure to thrive patient, or if they have a physical disability, then that could affect their behavior as well. Nutrition, developmental ability, intellectual ability, both of those will affect their behavior. Family interactions, family dynamics, you guys just finished your clinicals up, so you know that plays a big part in how kids act. Kids feed off their parents and their family, their behavior, so that definitely will affect that. All right, some screening tools that you might see used in the clinical setting. We're going to talk about a few specific disease processes. Autism is one. Autism is becoming more and more widely known because we're better at picking it up. You know, those mild forms of autism. We're better at screening for those, and that has a lot to do with the tools that we're using. There's lots of different tools out there to screen for autism. If you see a red flag, which we're going to talk about when we get to the chapter, then based on your facility's screening tools, you'll use one of these screening tools and evaluate the child. Anxiety, there's some scales that you might use to evaluate anxiety in kids. Some things that you might assess. You're definitely going to want to get a good health history, prenatal birth history. Ask things about in utero, was the child exposed to alcohol, because you have fetal alcohol syndrome that you might be dealing with. Before a child's born, that does affect how they behave. So prenatal history is really important. Family history, bipolar, schizophrenia, ask about those type of disorders. Any past medical history, because again, a child's physical health can affect how they behave. Any neurological injury. Kids with head injuries, sometimes they have some behavior issues after post-injury, so ask about any type of head injury or anything like that. And then, excuse me, developmental history is the most important thing that you're going to want to assess for. Those developmental milestones that gave you grief on the first and second exam, those things, if a child is lagging behind in his developmental milestones, his gross motor, his fine motor, then or his speech or his cognition, that may be a red flag for some sort of mental health disorder. Some behaviors you might see in kids. Hallucinations, definitely aggression and impulsivity, especially with ADHD, you're going to see that impulsive behavior, distractibility, getting frustrated easy, lack of sense of humor or fun, that flat affect that you learned about in psych, that could be a red flag to let you know that something else is going on, some sort of mental health disorder. Poor attention span, of course that goes along with ADHD. Any cognitive or learning disabilities, and we're going to talk about a few learning disabilities specific to children. And then any unusual motor activities like tics, like twitches that children may have, or habit, lip licking or things like that. Look for those types of behaviors. All right, some meds. Now there's a chart in the book, in the text, that gives the meds and the indications for the meds. So this is a nice little concise list. When we get to the chapter, it's going to let you know what each one of those medications are used for. Psychostimulants are probably the most common. Those are for ADHD. You might have some antidepressants, some clonidine. A lot of times that's used for behavior issues in kids as well. So when we get to that text, it'll give you a good indication of what each one of these are used for. It's not always the goal, if you find a behavior issue, to medicate the child. So first, we need to try some behavior management techniques. Okay, limit setting, routine, those are all very important in these kids. You want to set your limits and hold tight. Don't, just because it's easier, don't let go of those limits. Okay, redirection, focusing the kid on something that he can focus on. A lot of times in school, they allow these kids to just get up and wander around. They don't assign them a seat. They don't make them sit down, just because they learn better and they can pay better attention in that sort of environment. Restraints. We try not to use restraints in kids, only when it's necessary, only when they're going to harm themselves or others around them. Okay, remaining calm. Like I said, kids feed on adults' behavior, so make sure that you remain calm, you keep your voice low, and that way it won't provoke the anxiety in these kids. All right, what used to be known as mental retardation is now intellectual disability. That's the most current term for it. There are varying levels of intellectual disability, and there's a chart in the book that kind of goes through the IQs and what they classify them. But just know that the new term, instead of mental retardation, is intellectual disability. Okay, the middle bullet point here gives you a nice definition of it. Here's your levels: your mild, moderate, severe, and profound. I remember when we were in school, we took an IQ test. I don't think that they do that anymore. I'm not sure how they evaluate IQs anymore. All right, learning disabilities. Okay, there's 4 that we're going to focus on. Dyslexia, that's probably the most common. Again, it's because we are detecting it a lot more than we have in the past. Dyscalculia, problems with math. Dyspraxia, problems with manual dexterity and coordination. I think I have that. And then dysgraphia, problems with writing. Autism is one that we're going to spend some time on, and these are some warning signs of autism. So if you have a patient that comes in and you have seen them over a period of time, you're going to kind of know their trend. Real important to, I think they use some sort of screening tool. We used to use the Denver developmental screening tool with kids. I'm not sure that they use that one anymore, but there are milestones that you check at each visit. And if they're not meeting their milestones, then that could be a red flag. It could mean that we need to evaluate for autism. These are some really profound ones. If they're not saying a single word by 16 months, no 2-word by 24 months, or if they have language skills and then they lose them, that could be an indication that the child is autistic. Now, we don't really know what causes autism. It's kind of a puzzle, but these are some things that they are thinking that might. Genetic makeup, some sort of brain abnormality, an altered chemistry, whether it is a continual altered chemistry. You hear people say, I've got a chemical imbalance. Well, if it's a one-time chemical imbalance that affects the brain that way, possibility, or if it's an ongoing chemical imbalance. Maybe a virus that has affected parts of the brain and how the child acts, or toxic chemicals either exposed to them or exposed while they are in utero. All right, so autism is a spectrum, okay? There are kids that are very high-functioning autistic, and then there are kids that are profoundly intellectually disabled with autism. So there's a big spectrum. These families need lots of support no matter where their child is on the spectrum, okay? You're going to be doing a lot of petting, okay, supporting, encouraging, lots of emotional support with an autistic or with a diagnosis of autism, okay. Hook them up with support groups, kind of assess the coping mechanisms that you see within the family. Sometimes CPS needs to get involved because the coping mechanisms that you see may not be very good. So make sure that, and these kids are followed by psychologists, and they're followed by a team. So there's someone assessing all of this every time that they see this child. But if you're their nurse in a primary care setting, you're also going to be able to assess how they're handling the diagnosis. All right, ADHD is probably the most common that we deal with behavior issue. There's 3 different kinds. There's a combined type, then there's ADHD, and then there's ADD, which is just the inattentive, lack of focus without the hyperactivity quality to it. We're going to be talking about some eating disorders. Pica rumination. Pica is very interesting. I've seen some weird picas. We had a patient that ate the mattress, the stuffing out of her mattress, and she had a bowel obstruction from that. Hair is one that they eat a lot. Rocks, dirt, ice, those are all picas. And I don't know that they know for a fact, what triggers what you eat as a pica, but they say, if you're low in iron, that you'll eat ice or eat dirt to kind of make your body compensate, or to help your body compensate for that lack of iron. We're not really going to focus on rumination. We're going to look at anorexia and bulimia a little more in depth. Those are kind of adolescent focused behaviors, so that kind of fits right in with our week this week. Some complications that you might see. Bulimia, you're going to see probably a normal weight kid. With anorexia, you're going to see that skinny, very frail looking child. With both, you can have fluid and electrolyte imbalances. Decreased blood volume, cardiac arrhythmias, especially in the anorexic child. Okay, esophagitis. A lot of times they have scabs or abrasions on the knuckles from sticking their fingers down their throat. You can have tooth loss because of the enamel. The acid in the stomach as they throw up eats the enamel off the teeth. Menstrual problems, definitely. Sometimes these kids don't even have periods. And mortality rate is pretty high because of the cardiac involvement. Okay, so you need to know the word comorbidity. Okay, a lot of these disorders come with another disorder. Okay, they come in pairs, so that's a comorbidity. So if you have a child with depression that has ADHD, those are comorbidities. Comorbid disorders of depression, suicide. It's very, very prevalent in teenage age range. We assess every patient for a suicide risk according to the National Patient Safety Goals, correct? Anxiety disorders, a lot of times those go along with depression. Substance abuse, they try to self-medicate. Eating disorders and depression kind of go hand in hand. Self-harm, you see your cutters, the kids that burn themselves with cigarettes, and then some disruptive behavioral disorders. That's just kind of a catch-all category. Here are some risk factors for suicide, and I would know these. Previous suicide attempt, change in performance at school, loss of interest in what they usually loved to do, okay, and the biggie is having a plan. All right, here's some types of anxiety disorders. We're going to briefly touch on a few of those. Post-traumatic stress and OCD are real. OCD, that's a behavior type thing that, washing their hands or, having to lock the doors 3 times, or those are both examples of OCD. Post-traumatic stress can be any kind of stress, any kind of anything that was stressful. kids can act, have behavior issues after a divorce or after a death of a sibling. So those are some, whoops, don't want to go back. All right, let me see if I can go back here. There we go. All right, teaching topics. You know how there's lots of teaching interventions throughout the chapters. So you need to teach your parents, if your child is diagnosed with a mood disorder, these are some things that their parents need to know. They need to know how to give medication safely and monitor for adverse effects. If the child is suicidal, then monitor for any kind of indication that they might try to attempt suicide. They start to feel better on their antidepressant medication. It gives them energy, and then they have the energy to commit suicide. So make sure that you know that you teach parents how to watch for things like that. Support, again, support. These families are going to need the prevalence of child abuse in a family with a child that's diagnosed with a psychological disorder is very high. So lots of assessment, lots of coping skills, evaluation, all needs to happen for the safety of the child and the sanity of the family. All right, and one of the sad aspects of pediatric nursing is that you do see some abuse. You don't see a lot of it, but you will see it, and you need to know the red flags. You need to know what could be abuse. You need to know that you need to report abuse. It is your legal responsibility as an RN to report it. You can be held liable if you don't report it. So if you suspect, then you need to investigate. And if you investigate and find that there is a true concern there, then you need to report it. And you can report it anonymously. There's ways to do that, but your facility will let you know how you need to proceed if you discover abuse. All right, so there's 3 different kinds: physical abuse, sexual abuse, and neglect. That's just child maltreatment. Munchausen syndrome by proxy, very interesting. We'll talk a little bit more in depth about that when we get to the chapter. And then some substance abuse, especially in the teenage years. All right, Munchausen's. So Munchausen's is, and I know that you guys have seen this, it's been in the news, there's lots of information out there on it. It's when a parent is attention seeking and they make their child, ill to draw attention to themselves. They either physically give them, things to make them ill, makes them seem like they're sick. I've heard of people putting substances in the G button, or shaving their kid's head and saying that they had cancer and chemotherapy. And it's just a sad situation, feeding them salt water to dehydrate them. So it's really sad. If the symptoms don't really make sense, or it only happens when the parents are around, then you need to have your antennas up. Okay? If there's lots of hospitalizations, or if there are questionable diagnoses, then Munchausen's could be a player. All right, so let's get over to the chapter. I'll talk a little bit about some specifics. All right, some common medical treatments. Again, it's not about how you medicate, although there are some medications that we're going to talk about. But the goal of treatment is therapeutic. If we can get away without doing medication, then that's a great idea. Here are, again, some things that you can teach parents: set limits, remain calm, keep stimulation down, etc. Those are great teaching points for behavior management. Here is the table with the medications. All right, so like I said, the most common one that you're going to see are medications for ADHD. I like this chart because, of course, it gives nursing implications. Do you need to know the name of the drugs? No, you don't. It would be nice if you knew what class they are, like ADHD is treated with psychostimulants. That would be helpful. Okay, depression is treated with an antidepressant. So know your classes and know what the main treatment focus is. All right, here's your different types of therapy again. Now this is taking therapy. These aren't teaching points for parents. These are types of therapy used by therapists. Behavioral therapy, play therapy. Play therapy is huge in kids. So make sure you kind of have an idea of some therapy examples. Here's your nursing process. It does go into assessment, things to ask with the health history. Talks about behaviors. Okay. If you're interviewing the child, you want to look for things like this. Okay. Impulsivity, distractibility. You know, can the child sit still for the assessment? Those are all things to watch for. Okay. Here are some lab. You don't really see a lot of lab drawn in the mental health situation in kids. However, thyroid, it doesn't list it in here, but thyroid can be a big player. If they're hypothyroid or if they're hyperthyroid, that can kind of mimic hyperactivity, hyperthyroid. So you might see a thyroid level drawn. They might do a urine tox screen or a blood tox screen if it's an acute change in behavior and they think maybe it's a medication issue or an overdose. They might do one of those tests. MRI, CT of the head, if they're suspecting any kind of tumor or injury, then those might be done. Alrighty. All right, some learning disabilities, and we talked about these four. Would be important to know those four. Okay. So how do we manage them? They're very different in how you manage them. Therapy, one-on-one coaching, things like that for learning disabilities. All right, intellectual disability, again, we talked about that. It's the new politically correct term for mental retardation. Here's your classifications. You don't need to know your classifications, okay? Just know that there are varying degrees. Fetal alcohol syndrome. Fetal alcohol syndrome is very unfortunate. You know, a parent may not, or a mother may not realize that she's pregnant, be drinking, and then the baby born with some sort of fetal alcohol syndrome symptoms. So here are the symptoms that you want to look for, or the assessment findings that you want to look for. All right, autism. Okay, we talked about autism. Again, it's a spectrum. The spectrum of autism disorder ranges from mild, that's Asperger's type behaviors, to very severe. Okay. Usually you start to see these behaviors about a year, and it can be a lack of development of like language skills, or it can be we were talking and now we're not. So good evaluation, ongoing evaluation of these kids is really important. There's really no meds for autism. The main goal is to reduce their behaviors to where they are a functioning member of society, no matter where they are on the spectrum. Okay, here are some red flags. If they're not babbling by 12 months, if they're not pointing or using gestures, you know, waving bye-bye, no single words by 16 months, that's a biggie. Okay. No two-word phrases by 24 months, or if they lose language skills at any age group. Okay, ADHD, most common, okay? They say 10%. I think it's probably a little overdiagnosed out of convenience for whoever, but it is probably the most common. Now, there are certain medical disorders that might kind of mimic ADHD. One is sleep apnea. Okay, sleep apnea, the kids don't sleep at night, so therefore they're distractible during the day. They're not getting their rest. So tonsils sometimes come out, and ADHD sometimes goes away. So be thinking about that if you've got a kid with big old tonsils that's had strep a lot of times, that has a nasally voice, then their sleep apnea can be leading to lack of sleep, therefore their behavior changes. All right, this box right here on box 28.3 gives you lots of things to look for in your assessment. A child has to have 6 or more if they're 17 or younger in order to be diagnosed with ADHD. So these are the things to look for. Oops. All right, therapeutic management, you can use meds, but the goal is to decrease their level of impulsive behavior. Okay, that is the goal. So remember that. However, we have to do that. If it's behavioral management, or if it's medication, or if it's a combination of both, then that's what we need to do. All right, Tourette's, we're really not going to touch on Tourette's. Don't see Tourette's in kids that often, or I don't. Eating disorders, we talked about pica, we talked about rumination. Again, we're not going to touch on those anymore, but we are going to talk about anorexia. Okay, here's what you're going to see. This is what the anorexic patient's going to look like. Probably no periods, going to be low body temp, low blood pressure, and bradycardia. Okay, so everything is low. The nurse might also see like a fine hair. It's called lanugo on the end, and that's the same thing that like when babies get it. So they kind of revert back to that. So you might want to assess that, and if the patient has that, then look at their weight history. Again, this is really important to watch them on the growth chart. Continue to plot them, because you may see a change, you may see a trend downward. Okay, they can either do outpatient therapy or inpatient therapy with anorexia, depending on the medical condition of the child. So remember that. Refeeding, you don't want to dump a bunch of food, like cram a bunch of food down these kids, because they might go through what's called refeeding syndrome. And refeeding syndrome, if they're really, really malnourished, you can see some pretty big complications, neuro complications, cardiac complications. So you go slow, okay? And remember, you're going to see hypotension, decreased pulse, hypothermia, so everything's going to be low. All right. Mood disorders. Again, there's a big clump of mood disorders. Depression, bipolar are both mood disorders. Bipolar is treated with lithium. Depressive disorders are, of course, treated with antidepressants if needed. All right, some things to look for as when you evaluate for suicide risk. Those are all questions to ask. All right, and again, that with the National Patient Safety Goal, we assess every patient for suicide risk. Anxiety disorders, PTSD, and generalized anxiety, OCD. You can learn those as a group. If there are specific things like OCD that stick out to you that makes that different from the others, then I would definitely look at that. But anxiety disorders in general are treated with anti-anxieties if it's a medication, or coping techniques are taught. Some behavior modification might be good. Alrighty. Abuse. Again, abuse is very sad. Abuse is either going to be physical abuse, sexual abuse, or neglect. Now, failure to thrive, we're going to talk a little bit about failure to thrive when we get into the nutrition module, but failure to thrive can also be a form of neglect of abuse. So if you have a patient that is really skinny and they haven't gained a lot of weight, you may think of neglect as far as inorganic failure to thrive. All right, here are some questions that you ask. Now, we ask these as part of the screening process when the child comes into the emergency room. We ask if they're over 10, if they feel like hurting themselves or hurting others. Are you safe at home? Any concerns about abuse and neglect in the home? Those are all questions we ask as part of the screening process through the emergency department. You need to also ask those in every encounter with kids. Okay, if you're having trouble at home or if anybody's bullying you. I know the clinic across the street has added that as a question. All right, here's some sites of injury sites that you might, have your antenna go up if you see these. Burn. The only thing that's not highlighted here that I wish was the palms of the hands or the soles of the feet. Those are areas that if you see those burned, then that may be an intentional injury. Swatting them on the back, of course, bruises on their buttocks. These kids, okay, so let's take a toddler. Toddlers fall down a lot, right? So bruises on their shins, bruises on their head, they may not be indicative of abuse. However, bruises in various stages of healing on their ribs might be. So a good assessment, if you suspect something, is really important. Okay, there's an electrical cord mark. If you have a child that comes into or presents somewhere with signs and symptoms of abuse, again, it is your responsibility to report that, but then we have to have a safe place for the kids to go. So CPS sometimes gets involved, a lot of times get involved. The outcome, if we can place the child with a relative, that is a great solution, but sometimes foster parents also have to get involved. So CPS, if it's a severe enough case, especially if they already have an open case, then they will be pretty involved. Okay, Munchausen's. The official name is called Munchausen syndrome by proxy. And I do want you to read through this. But don't go suspecting every parent of having Munchausen's either. So just kind of be very objective, asking your questions. But here are some things that you might look for in a nursing assessment that might indicate Munchausen's. Substance abuse, adolescent problem, yes. Risk factors, if mom or dad, abuse alcohol or abuse drugs, then kids are more likely to see that and think that is the norm. Poor social skills, poor coping skills, lack of friends, those are all things that might lead to substance abuse. The need to feel like one of the crowd, okay, might be a big factor in substance abuse in the adolescent patient. All right, and then here is your care plan. Has a lot of teaching points for parents, interventions. So make sure that you read through that. All right, that's all I've got on this. Well, have a good night.